mammography also, this is the ASCRS thing that is recommended, LLPP. Always look for the lash, lid position, blink position and tear meniscus. Lift the upper lid and look for the superior conjunctiva for SLK. Upper lid laxity and flossiness, and push the lower lid and express the MG to see the mebum quality and quantity. So LLPC should be run routinely for all your cataract and any other refractive procedures as a primary procedure. So now mebography is not something that you need a special equipment. You can do it also with your existing equipment, or there is a simple DIY I will share with you. Then there are dedicated equipments and also IVCM if you have an access to it. So if you see, this is white illumination, and when there is surface IR illumination, you can stand out the meibomian glands. So these are different equipment that are available readily in your OPD, your autoref, NCT, IOL master, fundus camera, and even specular microscope. If you are able to just avert the lids, you can beautifully see the meibomian glands. The DY thing is the 850 nanometer light source that is available in Amazon. You can order it for around 7,000 rupees. And then once you have a camera in your mobile phone that has no IR filter, you can also identify the meibomian glands that can be looked like this. Next is dedicated mebographers that are available. So one of the first things that were introduced was the Lipi scan, where you can see the mebography here. It is also in My Healthscape, you have the Sirius and the Antares that have the mebography grading systems. Next, there is the EDRA, that is the latest thing that also gives you a 3D modeling of the meibomian gland and can show you the precise acini loss in each gland. So grading, depending upon the area of loss, it gives you an automated report of the degree from 0 to 1, 1 being least and 4 being the highest. So if you have an access to IVCM, you can also look at the lumen of these meibomian glands. So these are normal glands that have a good opening, lumen obstruction with minimal infiltration. This is moderate to severe and complete fibrosis and cell destruction of the epithelium. So next, coming to lipid layer thickness or non-invasive tear bud time. So this again, you can see it with LipiView from Johnson & Johnson. So if you have a lipid layer thickness of 100 and above, it's considered to be normal. Anything below the lipid layer, there is a deficiency. This can also be seen with the meibomian gland dropouts, and you get a comprehensive report of both of these in the LipiView. The next non-invasive thing is the non-invasive tear bud time. It's more precise and more better than a fluorescein strip that we see. So once you ask the patient to blink, here you can see those red spots occurring, and here you have the exact seconds in which the dry spots occurs on the ocular surface. So coming to the management of meibomian gland disease, we try to use doxycycline for its anti-MMP activity rather than its antibiotic property, and also add topical azithromycin and orally for these cases, and azithromycin and dexamethasone eye drops also can be used in these cases. Anti-inflammatory role of cyclosporin is well established, and rarely high dose steroids like dexamethasone or prednisolone are used. Usually these are used only in preoperative conditions where you want to rapidly stabilize the ocular surface. Lifitegrast and interleukins are not available in India. Though the DREAM study tells there is no role of omega-3 fatty acids, 80% of the ASCRS respondents have told that there is a role as an adjuvant therapy. There is no harm in using it. Omega-3 fatty acids, usually you use it for 3 to 6 months. And blepharitis and desmodex, you use tea tree oils. And this simple thing all of us can do in our OPDs is the mebum expressors. These mebum expressors are available from most of the surgical microsurgical companies. After warm compresses for a week's time, with gentle expression, you can remove the mebum from the glands in the OPD in this way. So next is the LipiFlow. This is the animation of the LipiFlow. So the advantage with LipiFlow is it also acts in the inner part of the lid, creating this compressions and heat, and thus expressing out the struck mebum that is there inside the acini and the glands. So that is the lipid flow in action, where it creates that pulse style motions along with the heat. It's more like your warm compresses along with massage. Next is the Ilux. This is from Novartis. Again, this is not available in India, but this is a very simple thing that you can do in your OPD again. So it catch holds of the lid, increases the temperature, and then you can just press it out to express the mebum from these conditions. So that is how it acts. And once you press it, the mebum is expressed in that. So next, intense pulse light. This is the thing that we are doing routinely. So far, we have done in 76 cases. Usually, we do it 1 month apart, and 2 to 3 sittings would be required. Combining with mebum expression and hot compresses yields better results. Usually, you get a wow factor after the first sitting. There is definitely patient feels symptomatically better and better non-invasive T-BUT. We do it routinely, not routinely, but in cases where there is compromised cornea in refractive surgery and premium IOLs. So whenever you diagnose the dry eye or compromised dry eye before surgery, it is the patient's problem. Post-operatively, it becomes the doctor's problem. This is the IPL animation. I'll skip it in interest of time. So these are the steps. Depending upon the skin color, the intensity of IRPL is adjusted, and we do it in 5 shots in each eye. 4 in the lower region and 1 in the lateral
you
canthal
can continue.
region. Yes, ma'am. And the last thing is the neurostimulation or nasal stimulation route. This is one more thing. New nasal stimulators have come that give rise to stimulation from the lacrimal gland because of the reflex stimulation. And tearing happens. These are the nasal stimulators still yet to be available in India. So MDG therapies, on a lighter note, in a way are like your spouse. You pretend to control it, but in reality, the control is only transient. Thank you.
Thank you, Madhu. You have touched upon every detail of MGD. Nowadays, MGD is overdiagnosed, I think. And what we usually offer the patients were like lid massage and warm compressors and all. And mammography also is one of the mandatory tools in the dry eye workup. Because if there is a meibomian gland dropouts, there is no point in continuing your treatment, isn't it? So you can document and show your patient this is the your meibomian glands. Majority are dropout. So there is no point in continuing. That is a advantage for doing this mammography. Okay. Can you on the lights, please? So we will take up a few questions regarding these two speakers, the previous talks. Any points to clear? So Dr. Madhu, what are the mandatory tests you do for a dry eye patient? You are having your own setup, no? Are you having a mammography and LipiView, LipiFlow and all? Is it mandatory to have it?
Ma'am, if you see the juice to recommendation, first would be the symptoms. So we either take the DUQ5 questionnaire, which is a shorter questionnaire when compared to OSDI that has more questions. But once the patient complains of symptoms, just does not have much of value. But after that, there are 3 sets of homeostasis tests in which you can do either one. So easily all of us can do without any equipment is the lysamine green staining and Shrimmers also, I would do it in the last, ma'am. Staining is the most important thing. If you have more than 10 conjunctival spots or more than 10 conjunctival spots or more than 15 corneal dry spots, or the lid margin is taking up the lysamine green stain, these are all indications that there is a definite problem with the ocular surface. Then you would go in with the non-invasive T-BUT that you can do either with the T-BUT that I showed you that's available in a lot of equipment, or you can do a invasive T-BUT. And then if you have access to osmolarity, they can do it, but osmolarity is not needed. But usually we depend more on the staining and then followed by non-invasive T-BUT. These 2 tests we rely on, and then we try to divide it into evaporative and aqueous deficient. Mostly what we see is the evaporative dry eye. Sometimes there can be a combination. So tear meniscus height also you can measure it in the slit lamp with a good graticule if you have a high magnification of the slit lamp.
So all those points is very important, I think. So we all think that all sophisticated tests are needed to diagnose your dry eye and treat your dry eye patients. But all these simple techniques, you can categorize your patients whether they are having MGD or any evaporative dry eye inflammation is going on, and so. And also we have our young corneal surgeon, Dr. Arjun from Comtrust. And Dr. Arjun, how will you do a Schirmer's test? Because for the sake of the PGs over here, what is a take home you give for a Schirmer's? What is a diluent do you use? Will you use paracaine or will you use a lubricant for the wetting of the, not Schirmer's, for the ocular surface staining?
Madam, fluorescein staining wise.
Yes, fluorescence.
Okay. If you follow the Japanese protocol, which they are going through, the staining pattern, you have to be very clear that usually take a strip of fluorescein, put, if possible, normal saline or some other solution, not a lubricant, and put it on the strip. Then you nicely shake the strip so that the minimum amount of dye is